trade-off of the patient selection is never easy, right? If you're doing something fantastic, the other side wants you to take care of a broader patient population, and then your ROI, when it comes to next year's reporting, goes down and down because now you're caring for less expensive patients, although you're doing the amazing thing that they actually need. So how does this impact some of your GI patients, right? Because some of them are super high cost to begin with Rise, and others are not today.
Not today, yeah. It's, I was talking to somebody earlier and they asked me whether or not we take, we're directly contract with primary care, and we don't right now. Our attribution model has us taking care of patients that have seen a GI within the past, say, 18 months or so, which means they're automatically a little bit higher cost. But then my number of patients I'm taking care of, just to your point, is a lot lower. And we also know from looking at the data that patients that have inflammatory bowel disease, it's very like this. So if you're managed, you're kind of flat. But a patient that is in remission right now, meaning and not on a biologic, they can like literally deteriorate overnight. There's something called silent IBD. I mean, so the primary care population should care. But you're right, it's almost like two different models for me. $40,000 total cost of care, $18,000 total cost of care. So completely different population. And I either have to decide like the big N is worth it, or we do two different models, which I'm sure there's like an actuary out here saying, no, don't do that, or a payer that has to do the reconciliation, right? We have to figure that out because it is tricky.
Or at least two-tier pricing, perhaps.
Yes,
right?
yeah.
So Rob, before we turn into the audience for questions, any advice you would give to a new specialty solution that's about to take risk now that you've been doing this for a while? Lessons learned, advice?
Yeah, I think that probably the two trickiest things are how to engage with the specialists, which varies, as I talked about, dramatically based on the specialty, I think, and just the other thing is back to sort of the economic discussion, I think, because that has two levels to it. One is sort of on a broad basis, how much can you spend on a patient versus the savings you're generated. But there's also a more short-term issue, which is most of what we get paid comes way down the line. There's a performance here, there's a delay, there's a settlement. We charge a program fee along the way to fund our operations, but that only funds so much. And so how do you manage your cash? And even though spending X might generate the right savings, I may not be able to spend X from just a cash flow perspective today. And so you've got to really be aware of that balance. And obviously, trying to generate more margin on your program fee may impact the savings you generate down the line. And so that's you've got to just balance it, and you've got to really, it only comes through experience. I don't know any other way to do it. But segmenting the population is extremely important, right? You just have to invest appropriately to the different patient groups.
Mike, I'm going to ask you a different question. Okay. You have payvider experience, right, as I do. Sometimes they're a more sophisticated buyer. They've already maybe reduced admits per 1,000 down to 175, 160 more globally, right? How do you make sure that whether it's behavioral health or some other entity that is doing specialty care, like the thing that they're doing is actually incremental to that more sophisticated buyer?
Great question. I think breaking it down to what the actual value levers are, getting really granular, like what is happening now that should be optimized, whether it's, like my dad's 87, he lives in South Florida, and his friends all get screening stress tests. They shouldn't be doing that. Asymptomatic. And so looking at, hey, are patients that are 85 or 90 years old getting screening colonoscopies when their life expectancy is short? And really breaking down what are the things that are happening that it should not be happening, and what's the value creation. So I think understanding that. The other one is really talking to specialty providers and understanding their day-to-day, their business models. And this was hard for me as a specialist going into a value-based care model, that it's directly at odds. When you're particularly a procedural specialist, your revenue is dependent on procedures. And when you move into value-based care, you teach the primary care providers to not call you and only give you the most complex patients, and sometimes that means you don't do a procedure, and that's scary. So I think understanding the perspective of the specialist, and then the last one I'll mention is not to forget what the patient wants. And in these specialty models, that patients often get confused and they're kind of bouncing around the system, and they kind of want to go to one person, one provider to help them make this complex system more simple. And so not to forget the perspective that these different specialty models have on actual patient care.